Hi, good evening to everyone. I'm Dr. Philip McMillan, and today I'm asking this hard question. Is the new presentation of COVID 19 going to be more of a viral sepsis as opposed to the severe disease ending up on intensive care that we saw early in the pandemic? This is an important question because I've always predicted a transition in the disease. Especially important because I've listened carefully to Geert Vanden Bossche, and he has predicted that soon we are going to see an awful situation with regards to COVID 19. So, listen, if you don't want to hear news that is concerning, you better stop right now because I am talking through what I think could be the next phase of COVID. I'll be talking about this new virus that's coming along, and I'll be looking at the clinical manifestations that I think could already be happening and are likely to increase in time. So, this is an important topic and one that we need to tease out to try and figure out what may be going on. Before I start, as usual, I want to mention to you the latest breakthrough that we have done. So recently, we were number one with Humming Heroes. It's not number one now, so we still need more sales, but that would be appreciated. But additionally, we have now created a chatbot. Now, the reason that I did this was because so many people were saying that my videos, they just can't see them. I have no idea why YouTube is hiding it, but for those people who are interested in all the videos, we're talking over 300 videos that we're putting together. This is where you will find it. You'll find the link below. Put in your email because we are planning to build a newsletter. So we want you to join. Once you've put that in, you can then jump to the next section. This is what it would look like. And this is where you will find the chatbot. And for example, if I put in here, Gert, and just put it in, what would then happen? It would produce information about Gert's presentations. These are all the presentations that I've done with Gert. This is absolutely brilliant. And so you can then click on any one of these and it will then take you. Oops, sorry, that one is not in place. But the point is that for the ones that are in place, say for instance, if I went up to say this one here, there we go. You would then be able to see that video with a breakdown as to what it was about. So this is exciting for us because it has allowed us to pull together all of the content in a way that it is very easy for you to search any questions that you have. So I look forward to hearing you and joining us with it. And please tell us how it works. That's the chatbot. But getting back to this serious question, this is a clinical question. And so I don't mind being challenged on this because I am explaining my thinking as to what I think is already occurring and will increase. And if we don't address it, could be associated with significant mortality. This is pretty serious in my mind. And it starts with the prediction that Gert had in the past few months. He put a date. I hate putting dates, but essentially, very soon, he believed that we would have a variant that would cause serious damage across the world. And one thing that I differed with the thinking on Gert is that I thought to myself, it's not going to present as severe COVID 19 in typical fashion. It's going to present as something else. And when I think about clinical manifestations, because not only do I do research, but I see patients and I reflect on what it is that I'm seeing in front of me, I think that viral sepsis is a pretty significant possibility. I think it may already be happening, and we need to understand how it will present. So, the first thing you have to realize is that there may already be the worrying variant that Gert was concerning about already here. So, just in case you're not aware of the latest bit of information, this is a preprint, virological characteristics of the SARS-CoV-2 KP.2 variant. This was published here in April 26, 2024. So just recently, just about within 2 weeks. And they were looking at the fact that the JN1 variant, which came out of BA 2.6, has now had another variant coming out of that, and that is the KP.2 variant. And so they are looking at the characteristics of this variant and where it's spreading to. Now, there's some interesting images here, and this is the breakdown as to what it is that they were looking at. So they looked at three countries here: USA, United Kingdom, Canada. And they were looking at the R0, which is the ability of the virus to spread in terms of its effectiveness. And when they compared it to the BA 2.816, this is one, it was below one, and then you have it rising for the GN1. But for the KP2, we're looking at about 1.2 to 1.3. So this is far more transmissible. And in the United Kingdom, it's appearing at about almost 1.3 to 1.5. Canada, about similar. So this is already across the world. And when we look at what's happening, the JN1 variant, that's the one that has circulated throughout the whole world. This is it in the USA. It has risen all the way up. The frequency, almost completely this is starting to fall off rapidly. And you can see down here now is the green upswing, and the green upswing represents KP2. In the UK, it's further ahead. So the UK is having a higher surge. Almost 20% of the cases now seem to be KP2. Canada is a little bit behind. So we can expect that because of what happens with travel, this is going to be a global surge. Now, some people will say that, listen, COVID is over. It's now just a minor cold. Well, if you say that, it's because you're not actually looking carefully at what exactly is going on with this virus. Now, whilst it may cause minor symptoms in the context of, a bit of sniffle, you have a headache, you feel a bit unwell, and then you get a little bit better, and then you may have longer term symptoms. This is the long COVID type of presentation. All kinds of things could be happening that people think are irrelevant. Let me warn you again. If you go back in history to the 80s, when we first had HIV, the symptoms of HIV in 4 weeks, the first symptoms were pretty minor. But if you left it alone, it would decimate your immune system down the line. There is something very unusual about this virus. And part of the problem is people keep underestimating this virus. I think it's largely because they presume it will follow the natural characteristics of other coronaviruses. Well, what you should learn if you're following the news is that they're still talking about a lab leak. If it was, this is not a normal virus. Really important point. So let me tell you what I'm concerned about, and I'll come back to this paper after I explain to you the science. So this is looking at this study here, which is Germany, out of Germany, and this was done in June 2021. So this was a good while ago, and they were looking at the lymphocyte subset counts in patients with COVID-19. I'll explain to you a little bit more about this in just a minute. But all you have to highlight, or all you have to understand, is that they were looking at patients who had moderate COVID and severe COVID, and they were looking at the cell counts of lymphocytes, B cells, NK, NK cells, cytotoxic cells, helper T cells. These were all reduced in patients with severe COVID-19. And the tendency was observed in patients with moderate COVID 19 as well. Now, again, people may assume that this is just a one off, but when you look at the numbers, and this is across the board, what you're finding is that the total lymphocytes here, this is the normal, this is what happens in COVID. So it's almost a 50% drop. And in severe COVID, it is completely decimated. B cells are absolutely hammered in terms of even moderate COVID, probably just a little bit worse than severe COVID. And you can see all the way through, all of these immune cells are absolutely decimated by the infection. So, one of the problems is people assume that if you have mild symptoms, it doesn't mean anything. So, here is me taking you through a little bit of the science. And as I said, I don't mind being challenged on this because this is important and I'm trying to figure it out myself. But let's walk through what I'm concerned about. We start with the basics as usual. This is the virus. This is this gray globule, and on the surface of it are the spike proteins. These are in blue. And you also have some M proteins and envelope proteins. These are dotted in red and yellow. And there are about 25 of the spike proteins on the surface. This is a typical viral spike protein. This is the top. It binds to ACE2 and gets into the cell. It's important to note that this is not the only thing that it does to get into the cell. It can get in with other receptors as well. But let's continue. Now, this is important to grasp, and I'm going to take you through this slowly. I did this recently as part of my Advanced COVID 360. The link is in the description. We go through this in detail to break down the science around it. But let me just take you through this simply. When we look at COVID 19, this is what I call the full spectrum of COVID 19. A significant number were asymptomatic. Sometimes they estimated up to 70%. A better term would be subclinical. They had inflammation, but they didn't really have symptoms. Another subset would have that 100-day cough, where they have this bronchitis, especially with Omicron. Not as much with the earlier variants, but certainly Omicron tends to cause this bronchitis picture. Then you have a viral pneumonia. These people could have a cough, they're producing sputum. Sometimes they get a secondary bacterial infection, they need antibiotics. Sometimes, depending on their respiratory state or if they have underlying lung disease, they can end up in hospital with a viral pneumonia. Moderate COVID and severe COVID is technically a viral pneumonia plus microclots. Severe microclots for severe COVID, I guess moderate microclots for moderate COVID. The critical difference is the microclotting. Microclotting, I don't think is going to happen as much because of the characteristics. It's not as much an autoimmune response because that was severe COVID at the time. It is now more of an inflammatory response. And so the picture that everybody is looking for with severe COVID 19, you're not going to see it. And so people will make the assumption that because you don't see severe COVID 19, there are no problems with COVID. That is just being not well educated as to how the disease manifests. This is why I'm saying I'm taking you through. I've been watching this now for 4 years. Every swing it takes, I'm following with it. This is now another swing, and you have to follow with me on it. So I've just got here a human body. This is just, I'll be coming back to this afterwards, but just so you're remembering, this is your head, your brain is up here. These are your lungs. The middle is your heart. This is your liver, a spleen, and then the kidneys below that. This is the intestines here, small and large intestines. Okay. When we think of the immune team, and again, I covered this in the advanced course, but I'll give you a short clip of this. This is what I describe as the immune team. You have the monocytes, which become macrophages or dendritic cells. Neutrophils are like the pawns or the foot soldiers. There are lots of them. They don't live long, and this is what tends to become pus if you have an abscess. These here are your heavyweights in the sense that your T cells are very important. They help to coordinate everything and they destroy viral infected cells. Your B cells will then become plasma cells, which produce antibodies and are almost like your missiles, distance targeting of the virus. And your natural killer cell, this is like your Navy. These guys just need to know where to target. I've included the mast cell, but for the time being, we'll keep this to the side. So this is the COVID immune team that I've put. And these are your primary, not completely, but your primary immune responses around this virus. Now, Here is again another clip from this is another slide from the advanced course. It makes it easy for me to put it together. But this here is now an important differentiation between Omicron and Delta. Now, this is something that I just noticed this recently, and I'll share with you this important thought. So they were looking at the timeline in this paper, and this was talking about the SARS-CoV-2 replication in airway epithelium, motile cilia and microvilli reprogramming. This is 6 hours, 24 hours, 48 hours. And this is Delta at the top. This is Omicron at the bottom. In Delta infection, the virus goes down the cilia, infects the cell. At 24 hours, it starts to spread. And then by 48 hours, it has infected all the cells around and it has spread outside and into the lungs. That's the Delta approach to infection, lots of viral particles. What's very interesting is Omicron. At 6 hours, again, it infects, but it infects 2 instead of 1. And additionally, by the time you reach 24 hours, it has infected 4 instead of 1. So 4 here are infected in red, 1 is infected compared to Delta. And then by 48 hours, it is as well spreading lots of virus. Now, one of the questions I asked myself is how is it possible for by 6 hours before it even does its full replication cycle, it's getting into other cells? And by 24 hours, because the replication cycle is about 10 hours. What it seems is that it has the capability to spread through cell to cell transmission as well. So not only does the virus spread this way, but directly it moves from this cell to this cell. Now, this is very, very important. It may seem like a small point, but it's a very important point because as I talk about viral sepsis with regards to this virus, you'll realize why this is critical to understand. Now, again, let's get back to the science of it. This is how a virally infected cell is usually destroyed. So if you imagine this is here a virus infecting a mucosal epithelial cell, goes in, it doesn't go in the nucleus, forget that, but it infects the cell. In this one, it's producing viral RNA. But it triggers the immune system because a piece of the protein of the RNA is put on the surface. And because the immune system, these are the T cells, recognize this as being foreign, they come and kill this infected cell. And so suddenly now, instead of you having thousands of viral particles spreading, because this immune cell came along and destroyed it, it can't spread. And this is a critical way that the body deals with viruses, different from bacteria. Bacteria uses a slightly different system, but for viruses, because you want to destroy the affected cell, you need these lymphocytes. Okay? So I'm taking you step by step why this viral sepsis point is so important. So let's take it back to what I told you about the lymphopenia. The lymphopenia is where the lymphocytes have disappeared. Suddenly now, this COVID immune team doesn't have the planes, doesn't have the Navy, doesn't have the missiles. It's gone. It's left with neutrophils and monocytes. The mast cells are not really there to deal with it. They are like a backup, but it will just cause activation of the mast cells. So I'm not sure what will happen with these. But what we're left with is primarily monocytes and macrophages, and the rest of the immune system here has been taken out by the infection. One of the remarkable things about the virus, the spike protein, is that it can enter immune cells using CD147. This is technically very similar to what happens with HIV. It enters immune cells, makes them not function or die, and that's how people are prone to severe infections. So the viral sepsis now is there where we have a situation where the body is not able to control effectively the spread of the virus. Now, again, let's take one more step. So I've got here an image of a blood vessel. And these here represent endothelial cells lining the blood vessels. And in viral sepsis, the virus has gotten into the bloodstream and it can enter these endothelial cells and replicate. If you don't have a good immune response with lymphocytes, you can't control this replication. And you will have ongoing circulation of virus that is very difficult for the immune system to control. That's the beginning of the viral sepsis. Now, viral sepsis is different from bacterial sepsis. And I'm going to kind of take a slight shift from this because I want you to understand that viral sepsis is it's there, but we don't. From a clinical point of view, it is not quite the same as bacterial sepsis. I've got this whole sepsis thing together just so that you understand. So here we have viral pneumonia and sepsis. This is taken from the Sepsis Trust site, and they highlight that a significant majority of episodes of pneumonia outside the pandemic are caused by bacteria. And these are typically the kinds of pathogens that cause pneumonia, including fungi, especially in immunocompromised people. However, in the context of COVID, they're recognizing that viral pneumonia with sepsis is becoming far more serious, and we are losing lots of lives because of sepsis. And you have to realize that the sepsis that occurs with viral pneumonia is actually complicated by the fact that the inflammation in the lungs will lead to secondary bacterial infection. And this is why many patients who have these ongoing symptoms, they seem to have this chest that doesn't go away, they get antibiotics and they improve, but they don't get back to normal. So the antibiotics improve, get rid of the secondary bacterial infection, but it doesn't resolve the viral sepsis. So this is where I think, I know, this is me taking the steps. So my question is, if you have viral sepsis, even if you had a pneumonia, it's not going to be the same kind of pneumonia as you had with severe COVID-19. And so patients will get sick. They may need a little bit of oxygen, some antibiotics, and they get somewhat better. But it won't kill them. It won't get them on intensive care unless they already have underlying lung disease. Where, therefore, will viral sepsis manifest most frequently? So that got me thinking, and I'll show you now where I think this is going to present. Brain inflammation, because if you take that same picture, the virus is circulating and it's infecting endothelial cells all through the body. When it reaches the blood-brain barrier, nothing is supposed to pass this. So the virus can infect the liver, it can infect the kidney, it may cause a bit of inflammation, but in the context of the brain, if virus gets across this barrier, it triggers quite a significant immune response. And this is what I've represented here. Virus getting across, you then get this very strong immune response occurring inside the brain because you have now infected endothelial cells. And so, if I'm right, the primary mechanism that we're going to see surging is unusual neurological presentations that are occurring along with things like a viral pneumonia. And the manifestations of this brain inflammation could be myriad, including spinal cord inflammation, headaches, confusion, encephalopathy, seizures, stroke, really complex stuff that is very difficult to figure out if you don't know what you're looking for. This is why I'm raising the question now, because I'm hoping clinicians are going to see some of this. I want them to think about it. I want them to challenge it. I want them to say, no, 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 you're wrong about this because of so and so. It doesn't matter. The most important thing is that people think about it, reflect on it, and try and come up with answers for it. So, as I think and I reflect, if we have a situation with KP2 where in a significant percentage of the population it is ongoing circulation because they have chronic lymphocyte dysfunction from the viral infection, so therefore the immune system can't properly get rid of the virus. How does that present? How is that clinically going to present? And so I come back to the human body here. And in this case, you could end up with, as I said, a viral pneumonia. So you'd have a viral pneumonia with secondary bacterial infection. They'd be producing sputum. You treat them with antibiotics. They seem to get somewhat better, but not fully better. You could end up with inflammation with the heart. Now, that's very difficult to identify because oftentimes the only symptoms you may get are things like an irregular heartbeat. If you get any sudden arrhythmias, that could lead to death. But very often it's just abnormal rhythms that could occur with those people. The liver can be affected, but again, the liver is pretty resilient. So I wouldn't expect to see too much occurring with the liver. The kidneys, I suspect, could also be affected. And in kidney disease, what you're going to see is just a deterioration in kidney function. So if somebody had no kidney disease before, you'll not see anything. But if somebody had already pre existing kidney disease, what will then happen is that their kidney function may worsen. And that's how they will present in the context of this viral sepsis. I can't explain to you just how significant this is. And so I'm bringing to you some pretty important points. But whichever way we take it, just remember the slides. This is what it looks like. This KP2 is going to circulate again through highly vaccinated regions: USA, UK, Canada, anywhere else. JN1 is going to disappear. Our question is, KP2 is evading all of the immunity that was produced by the vaccines. And so, therefore, you are going to have ongoing viral infection in these areas. How long will it take before that manifests as significant disease? That's the question. And that's where I am worried. And that's where Geert has been worried, because this is essentially what he predicted. A lot of people have said, Geert isn't right. I'm saying, no, Geert has to be right, because he identified that the immune system could no longer cope with the transitions of the variants, and it was starting to no longer respond with with antibodies. It was shifting primarily to the T cells. But if you then get viral sepsis and the T cells are destroyed or decimated, then the immune system is unable to fight. This is pretty serious. And again, just so you remember, and from a clinical point of view, what I'd say to clinicians is this is what you look for. Look at the total lymphocyte count. If you are finding consistently that a lot of people who come in have very low lymphocytes that don't fully recover, it is probably going to indicate that their lymphocytes generally have been decimated by persistent viral infection. Even that mechanism that we have to figure out is, how does the virus do it? I think it's the CD147. So it's technically doing a similar thing as HIV. It's infecting the immune cells, and the immune cells are dying. And I don't know if this is a response that the immune cells do to protect from further viral replication, or whether or not the virus is causing these lymphocytes to die. But whichever way we take it, this is a problem. So I need people to start thinking, because if we wait until it reaches a point where the excess deaths, because what you will see is excess deaths will first be 5 to 10%, then it will go to 8 to 12%, then it will go 12 to 15, then 15 to 20. By the time you respond at 15% excess deaths, and people say, oh my goodness, something is going on, the horse has bolted. To be frank, I don't even know with regards to KP2 now It's already 20% across the UK. It's going to continue to spread. Even if we intervened now, would we be able to stop it? I don't know. One thing is for certain, if you don't try, if you're not utilizing whatever strategies you have, there is no opportunity to mitigate. So this is a serious conversation, and I'm raising it because I think it needs to be reflected on. Why are we not hearing this from public health? I don't know. It seems as though people are now afraid of being wrong. I'm not afraid of being wrong. I'm afraid of not saying anything and being right, and then it causing a problem for the population at whole. So this is a situation where I really don't mind being wrong. Because if this is right, one, we are already seeing the concern that Geert had. It's just that nobody knows. They haven't yet recognized it. And we haven't at all prepared. And we will be caught off guard if this continues to happen. There's still a long road ahead of us. Whichever way we take it, whether it happens this time or with the next variant, it seems inevitable, unless there is a strategy that allows the population to suppress the viral circulation. Sadly, what needs to be done is going to be the same things that had been suggested before and had been ridiculed, because there is nothing left in the basket. Serious times ahead. Again, as a final note for, I guess, more pleasant stuff, remember to look at the link below for our chatbot. That's where we have our links. Join us in terms of the newsletter. We'll keep you updated with regards to this stuff. And if you really want to understand the science, please join me on the Advanced COVID 360. This is where we are so far. We've gone through part 1, part 2, part 3, now into part 4, and we still have more parts to come. So this is very valuable if you are interested in the science. So thank you all for being with me. I hope that you have a wonderful evening.